All right, good morning. We're just around 11 o'clock, and I was just wondering if you wanted to fill in and come up front to this session, which is going to be all about integration of different care services across the continuum of care and across the needs of people living with HIV. So the title of this symposium. Okay. If you would like to come on down front, please, we invite you to do that. This symposium is Integration of HIV with Other Care Services. And we have a jam-packed group of experts who have been working in many different diverse areas on integrating diverse services. So we start out with different parts of the world in Asia, Eastern Europe, looking at HIV integration with drug use and key populations, people, men who have sex with men and sex workers, as well as substance abuse integration programs. And then we move into maternal and child health, and finally into the broader universal health care SDG agenda of how are we going to be addressing the booming and burgeoning NCD agenda, and we'll end up with a discussion there. So we hope to have lots of questions and lots of time for questions from the audience. So with that, I'm Meg Doherty, WHO and HIV department, and I'd like to pass over to my co-chair, who will be chairing the first part of the session.
Thank you, Meg. I am Jean-Pierre. I am an addictologist and mainly working in the southwest of France in the field of addictology and harm reduction. And we are working too in Vietnam in several programs with the aim to integrate, to have a comprehensive treatment with treating addiction and hepatitis and AIDS too. So, my pleasure is to introduce Shruti Mehta from Johns Hopkins, and she's deputy chair of the Department of Epidemiology, very well known in the world of epidemiology. And she received a master's in public health and a PhD 2002 in epidemiology. Also, I'm sorry, okay, in epidemiology also from the Johns Hopkins. Her research focuses on HIV and hepatitis Hep C infection among people who inject drugs in the US and in India, with a particular interest and focus on identifying and overcoming barriers to access care and treatment for HIV and HCV. You can go ahead. And waiting for the slides. I apologize. I take profit to apologize for my English. It's more a Friendlish, which may be better for the French speaking people, but less for the pure English speakers.
I did. Maybe give it a second. I think it'll be okay in a second. Well, we'll see. Or do you want to switch the order? We could do that. Oh, here we go. It's in the middle somewhere, but I think I can get there. All right. Well, while I get to my slide, I want to thank the organizers for inviting me to speak. It's really a pleasure to be in Paris and to talk about some of our ongoing work with integrated service delivery across India. So first I wanted to start with why our focus is on people who inject drugs and men who have sex with men. So in India, these two groups share a large burden of HIV infection. Sorry, I can't quite get to that slide. Whereas the prevalence and incidence have declined in other risk groups in India, in particular women attending antenatal clinics STI clinic attendees and female sex workers, we haven't seen that same trajectory among MSM and PWID. Particularly, the prevalence has remained stable and is actually increasing in some settings. Some epidemiologic data, including our own, actually suggest that the prevalence is higher than what you see here. But despite this incredibly high burden, we see very suboptimal engagement in HIV care. So these are actually data from the baseline sample of the trial that I'm going to talk about today, where we sampled people across 27 locations in India. And what you see is that fewer than 40% of infected individuals were even aware of their status, and fewer than 15% of both groups had suppressed viral load at the time of this survey. And this was in 2013. Both groups face high levels of stigma and discrimination, which also impedes their access to services. And like in most settings, services are fragmented in the sense that HIV testing, opioid treatment, needle exchange, they're all delivered in segregated centers. And so at baseline, what we also found is that most people across their lifetime hadn't even accessed multiple services. So you can see from these figures a lot of missed opportunities, people accessing needle exchange or opioid treatment, but never before having an HIV test. So in 2002, our group launched a large cluster randomized trial across India to test the hypothesis that integrating key HIV prevention and treatment services with other critical services could actually improve uptake of HIV testing as well as engagement across the HIV care continuum. Our intervention is a one-stop shop, essentially for all the services that you see listed here, so HIV testing, treatment, key harm reduction services, TB treatment, and general medical care. The idea is also to, of course, deliver these services in environments that are tailored to the population. On the right, you can actually see the design of the study. So essentially, the intervention is sandwiched between two cross-sectional samples. So at baseline, we conducted cross-sectional serosurveys in 27 candidate cities across India. We selected 22 of these for the trial. 11 were randomized to receive the intervention, and 11 the control condition. So in the intervention sites, the integrated care centers were scaled up and run for 2 years. In the control sites, all services were available, but in segregated centers. 2 years after the intervention, we ran a second cross-sectional serosurvey, sampling again 1,000 people per city in the 22 sites selected for the trial. In this map, you can see a little bit more closely where we actually are. So on the left are the MSM sites, and you can see we're mostly in southern India, which is where the historically high HIV prevalence states have been in India. For the PWID sites, we're in northeast and north and central India, reflecting the epidemiology of drug use. So northeast India has sort of the more historical drug use epidemic. North and central India have the more emerging epidemics. And you can see the squares here are the intervention sites, and the triangles the control. So how did we do this? So it is really a true public-private partnership. We are partnered with YRG Care, which is an NGO in India, and the National AIDS Control Organization, and we've worked together to figure out the best way to scale these centers. We did not start from scratch in most places. We decided to take what was already there. And so for the PWID stratum, this was taking basically opioid treatment programs. This gives you a sense of what the places look like. This is one of our centers in Imphal, Manipur, where we scaled up. This is actually an NGO. And in some sites, in particular northeastern India, we built out of NGO models. In North India, we primarily built out of government centers. And in some of the cities that we were in, no opioid treatment existed, so we actually had to start from scratch. So essentially what we did was bring in supplemental services. So in India, HIV testing is typically done in government-supported integrated counseling and testing centers, and then ART is typically delivered in separate centers called government ART centers. We've been able to bring HIV testing into our ICCs, so we do rapid HIV testing on site with confirmation of results of the government center. ART, we've been able to integrate ART, on-site ART, into some of our clinics, but for the majority, actually, we've had to deliver ART through a link model where peer health workers actually facilitate pickup and delivery of medications as well as visits to the government center. These are really our core services for people who inject drugs, but we've also integrated other services, namely counseling, condoms, STI syndromic management, syringe exchange, which is both within the fixed site and also field-based, TB testing we do within the clinic, so we provide the sputum collection containers, but we link with the government DOTS programs for people who test positive. And then finally, some general medical care. And so, like I said, this is a public-private partnership, so the government really provides the services, so we get the test kits, the opioid treatment, the needles, the condoms from them. What we provide is some additional staffing, training and sensitization, and particular community outreach. This gives you a feel for what one of our ICCs looks like. This is one of the PWID NGO-based ICCs, and you can see here we have 2 nurses in each of our sites, one that delivers opioid treatment and the other who provides other services. In that sort of fuzzy picture is our counselor, and then in each site we have a doctor that comes for various periods of time, and that's the doctor's room. These are 2 of our ICCs in government-based centers, and you can see a little bit of a different feel here, but it also gives you a sense of the size of the staff, minus some U.S. visitors that are in there, as well as the size of the crowd at one of these ICCs. The one that you see the large group of people in is actually our site in Ludhiana in Punjab, which is our busiest ICC. We see about 200 clients a day. In some cities, because of huge crowds, distances, safety issues, we were actually forced to open more than one ICC. So in Imphal, in northeastern India, essentially there's just constant military insurgents. It's difficult, it's unsafe for people to travel long distances, so we have 3 ICCs. In other places, there was just a lot of distance between where the largest pockets of people were. This is data from our baseline sample, and you can see in the city of Chandigarh that people were really concentrated in 2 different locations. Looks like a small distance, but for those of you who've been in India, you know that this can take upwards of 3 hours to travel. For MSM, the model looks very similar. Obviously, no regular requirement for opioid treatment, so instead the center of our model was the government ART center. And surprisingly, we actually ended up scaling out of the government centers for most of the MSM ICCs. So 4 of our MSM ICCs are based in government centers, 1 in an NGO. Otherwise, the services are very similar. Obviously, we don't need much needle exchange or opioid treatment. So over 2 years of intervention, we don't have our final results yet. We're anticipating those in a few months, but what I'm showing you here is just some utilization data from the 2 years that the clinics have been open. So we've registered 11,000 people who inject drugs across the 6 PWID ICC cities. You can see some variability across the sites. Overall, there have been 750,000 or so visits. Our busiest ICCs are in Imphal, in Manipur, which is in the northeast. Again, that's where we have 3 ICCs. We see the most clients per day in Ludhiana, that picture that I showed you where I mentioned we see about 200 a day. In the MSM ICCs, we have 5 of those. We've registered 7,000 clients and about 25,000 visits. Fewer visits, of course, because no daily requirement for opioid treatment. You see high uptake of all services across the board at all of the ICCs, and I don't show the overlap here, but definitely an increase in the number of people accessing multiple services. In particular, the most commonly utilized service was HIV testing, which is good because that's the primary outcome of our trial, but we had many people that were coming in just to get needles or just to get opioid treatment, and we've been fairly successful at engaging them in HIV testing. Similar picture with the MSM sites. The most commonly accessed service is HIV counseling and testing, followed by STI screening. So I wanted to spend the last few minutes talking about some of the challenges that we faced. And I'm going to just briefly touch on a few things, and I'm happy to elaborate on any of these in the discussion. So, I showed you some overall numbers of what care looked like across the settings, but what that doesn't show is how diverse these populations were. So we are working across the country in very diverse settings with diverse HIV and drug use epidemics. So just to give you a flavor for this, I've pulled some data from the IDU sites, and what you can see is diversity from basic demographics, what drugs people are using, to the services they're accessing, right? So in the Northeast, you'll see we've got a mix of female and male people inject drugs, but no women across North and Central India. You can see a predominance of heroin injection in the Northeast, but very little in North and Central India, where there's more buprenorphine or pharmaceutical drug injection. You see variability in service access, right? In Northeast, where we have these historical epidemics, you see, reasonably high prevalence of having ever had an HIV test, but very low prevalence in some of the more emerging epidemics. In particular, Kanpur, you see only 8%. The HIV epidemics are equally diverse, so this gives you, again, just in the PWID sites, to give you a flavor, prevalence and incidence, right? And so you see very high prevalence in the Northeast and low incidence, lower prevalence in the more emerging epidemics, North and Central India, extremely high incidence. And then I showed you this overall picture of HIV care engagement for both PWID and MSM, but what you didn't see is how variable these estimates really are. So if you look at the range across the sites, we actually go from about 3% in Kanpur to about 95% in the northeastern city of Gangtok. So it's just been, it's been really interesting to work across these different settings, but we face different challenges with the types of populations and the types of models that have been needed. I mentioned our primary outcome is HIV testing, and we've seen fairly high uptake of HIV testing. Again, the results are not out yet, but secondary outcomes are awareness of status, engagement in care, and viral suppression. We've not seen the high levels of HIV care engagement that we expected. So just to give you, again, a sense, this is clinic utilization data. You can see that fewer than 50% really of the positives have ever received HIV care in the clinic, and even fewer have initiated ART. And you can see that the majority, this is the PWID stratum, are from one site. This is Imphal, again, in the Northeast. Similar picture among the MSM sites. Again, fewer than 50% have engaged in HIV care at the ICC. I mentioned at the outset that this is a public-private partnership, and so the government is providing things like test kits and condoms and needles. We did that because we wanted to ensure sustainability of the model, right? If we could show that this worked, then after we left, there was a stronger chance of it being sustained. But we did have the capacity to support sites if there were stockouts, right? And we definitely did face stockouts, and we've had to support various sites at various times with different test kits, opioid treatment, and needles. So for example, the government's had shortages of HIV kits. We also, when we first started, we had one state split into two. Right, so one of the states, basically one of the new states, had no health resources. So literally we supported every activity in that ICC at the beginning. We've since then been able to scale back. But this is a challenge, again, if you think about sustainability. And then finally, I showed you our utilization numbers, and we've definitely reached large numbers of individuals, but we still feel like there's a core population that we're not reaching. We had this sort of we build it and they will come model with a lot of outreach, but there's a large population that we're not accessing, and we know this because of our baseline sample. So our baseline and evaluation samples were accrued using respondent-driven sampling, which is a network-based sampling method, and we were able to reach large numbers of individuals within really short periods of time. So 3 to 6 months. In each city, we reached 1,000 individuals. This is for both PWID and MSM. And in many of the sites, we reached people who were infected and unaware of their status. So this is just one example in Kanpur, where we reached, the prevalence of HIV was about 30%, Hep C was about 60%, and most were unaware of their status, right? So a way to truly reach people out of care that we're not necessarily getting in our ICCs. And for those of you that are interested, Sunil Solomon in our group has a poster on RDS and its potential for reaching unaware individuals. So with that, with the data that we have and the challenges that we faced, what are we looking to do next? What are the next steps for us? So as I mentioned, the final results of the trial, the evaluation sample has just completed, and so we expect our results probably September, October of 2017, so stay tuned. In the meantime, we've already begun a second phase of our integrated care clinics, and this is based on our utilization data that shows that we seem to be reaching people for a single HIV test, but engaging them in long-term care and treatment is a little bit more challenging. And so we feel like we've maybe increased the supply of PWID, MSM-friendly services, but perhaps we need to increase the demand. So we're going to supplement this with a demand-based strategy, specifically non-financial incentives. So that's already underway. I didn't mention Hep C because just I didn't have time, but we have started that, obviously a key service needed for people who inject drugs, not provided by the government of India universally thus far, but we are working to integrate this into our ICCs. And then finally, this issue that I think for us, it's the one that's been the most troubling is we feel like we're not reaching this large group of individuals. So again, Sunil Solomon and our group is a new project working on trying to leverage respondent-driven sampling and other network-based strategies to identify infected and unengaged individuals. I want to just take a moment to thank our funding sources, which have been many. We've been well funded by the NIH, also the Indian Council of Medical Research and the Elton John AIDS Foundation. Many collaborators. This work is obviously represents a collaboration of many individuals across the U.S. and India. It's truly been a team effort. The National AIDS Control India, who's been a key partner for us, and then finally all of our site staff and participants across India, without whom none of this would be possible. Thank you very much.
Thank you, Shruti, for this wonderful presentation. We emphasized very critical issues, and especially the importance of the testing before all. We will keep the question and answer after the four speakers. And now, it's my pleasure to introduce Frederick Altis from Yale University. He's involved in epidemiology and public health. His research interests are in developing, testing, and implementing interventions focused at the interface of infectious disease, HIV, TB, HCV, and such substance use disorders. His behavioral research spans multiple key populations, including MSM, female, and transgender, sex worker, etc. He works in several international settings, including Southeast Asia, Eastern Europe and Central Asia, South America, Sub-Saharan Africa, and the US, obviously. Specifically, has been interested in how effective treatment of underlying substance use disorders influences infectious disease treatment and prevention outcomes. Professor Altis received his doctoral training in Emory University, his postdoctoral training at Yale. Well, you can go on.
Merci, and thank you all very much. Thank you for the organizers and for the co-chairs for inviting me to present on behalf of a number of people on the integration of addiction, HIV, TB treatment into primary care settings. It was actually really nice to see the incredibly impressive work that Shruti presented on behalf of her group. This has some similarities, so there are some efficiencies here. I'd also like to acknowledge individuals within Ukraine, many wonderful collaborators, my colleagues at Yale and Health Qual, as well as the National Institute on Drug Abuse for funding, and these are my disclosures. So most of the work that I'm going to be presenting, not only the pilot work, but the cluster randomized controlled trial, is done within an implementation science conceptual framework. The cluster randomized controlled trial will be using a hybrid 2 design, but we've been mostly using the Paris conceptual framework, which really looks at evidence, context, which is going to be in the Eastern European setting, and issues around facilitation, because facilitation has been the single most effective part of implementing interventions. So first, let me start out with the evidence. That in Ukraine, mathematical modeling studies have shown that opioid agonist therapy with either methadone or buprenorphine is the most cost-effective strategy to reduce HIV incidence, and scale-up in prisons with retention post-release is similarly effective at reducing new infections. We have identified already there's a number of individual clinical and structural and policy factors that have undermined this scale-up. Part of what I'm going to be doing is moving it into a new setting. We've also demonstrated that OAT improves each step of the HIV treatment cascade in Ukraine. And we're now at a really critical juncture where two important things have happened. Regulations at the government level called Order 200 now allows for opioid agonist therapies to be given as take-home doses through prescription and moved into non-specialty care settings. And then the healthcare reform, which is just underway, all of this happened in 2016, really has a focus on strengthening primary care, including financial incentives. What we do know is that with regard to integrated care, it is for individuals who are people who inject drugs, it is recommended to integrate addiction treatment, HIV, and TB services by numerous organizations. It's been effective for a number of diseases, but it has not universally been effective. And models for integrated care are diverse. You saw some of what Shruti did in India. It can be complicated. It can be done through linkages and communication by navigators. You can co-locate services but have distinct staff, or you can have full integration where you have one-stop shopping. Now, within this context of Eastern Europe and Central Asia, it's the only region globally where HIV incidence and mortality continue to increase, especially concentrated in opioid-dependent people who inject drugs. And most of the mortality among people living with HIV is related to tuberculosis, including MDR and XDR-TB. Now, one of the unique things about the healthcare system is that it's part of the Shamasko Soviet system where narcology and all healthcare is siloed. They have addiction treatment called narcology, where there's incredibly high stigma, not only towards people who inject drugs, but to opioid agonist therapies. Opioid agonist therapies were first introduced not as addiction treatment, so you can imagine putting this into the hands of the people who don't really believe in it, as HIV prevention, but not actually for the treatment itself. There is a specialized healthcare delivery system, but now there are some new moves to move these kinds of treatments into new settings. This is Ukraine. It's the largest country in Europe. It's not as big as India. We didn't have quite as many complex issues, but nonetheless they are there. It's a middle-income country that has a large number of people living with HIV and people who inject drugs, but with incredibly low coverage, not only of antiretroviral therapy, but with opioid agonist therapies. We're doing most of this research in the areas that are most affected with HIV and with people who inject drugs. And I just want to point out and remind folks that this is a country in conflict where Russia has annexed Crimea and all services have mostly disappeared. And then there is ongoing conflict areas in the Donbas region where there are still outreach efforts in order to provide services. So one of the questions is, why move this into primary care settings? And one of the first reasons is that patients with psychiatric or substance use disorders on average die 25 years earlier. And it's not because of their addiction problems, it's really the sort of other primary care issues that are not really being addressed because they're getting most of their care in a specialized setting. We've demonstrated some evidence of integrating buprenorphine into HIV clinical care settings, really improving HIV treatment outcomes, but also other quality health indicators for primary care diseases. And so we've moved to the concept that integrating care can't just treat the addiction or the HIV, but if you really want to have a good measure of integrated care, you have to look at quality healthcare indicators across the spectrum of conditions, including primary care and all of the factors that you're seeking to overcome. And then I'm going to present some pilot data, which it really helped guide and coach us to the cluster randomized control trial that I'll be talking about. This was done in 3 settings. We took individuals who were on methadone and we either transferred them to primary care settings, so these were the transfer patients, or we took individuals and we newly induced them onto methadone treatment. One of the things that you see is in the patients who were transferred, we have incredibly high rates of retention and treatment 6 months afterwards, over 90%. For the new initiates, it was about 83%, which is about the numbers that we have in Ukraine already. So we had a good proof of concept that at least with one outcome, that is the addiction treatment outcome, you have a benefit. The question is, from an implementation perspective, did it have any other benefits? One of the things that we learned and we measured using standardized scales is that at the patient level, stigma levels were markedly introduced by coming out of these specialty settings and being in a care setting that didn't actually label them as a drug user. They had increased health-related quality of life during that transfer, and their trust in physician levels increased. We confirmed all of this with qualitative interviews as well. But we also did provider surveys and chart reviews, and we found that there were increased uptake of screening and diagnosis and referral for treatment for both HIV and hepatitis C. There was facilitation with initiating antiretroviral therapy for the 60 or so % of patients who had HIV, and they were also being seen regularly for their medical issues. One of the things that emerged from this is that the clinicians felt uncomfortable with dealing with these sort of non-primary care diseases because of the sort of the history of treatment where all of this was done in specialty care settings. And so they said they needed ongoing coaching, even though they had some baseline experience or training at baseline. And they also additionally requested some assistance with screening and treating of depression. Let me show you some of the data with regard to the staff level outcomes, and this was using a feeling thermometer in terms of the staff's attitudes towards people who inject drugs and people living with HIV. These are in the transfer patients settings. What you see is that the feeling thermometers increased over twofold for people who inject drugs, and it increased significantly, at least for HIV-positive patients as well. So this really supports the contact hypothesis that when individuals actually have real live contact with somebody from a disdained group, that they actually improve their attitudes toward them. What we recognize is we had to come up with a facilitation project because this is the single most important part of implementation of new interventions. And what we were really looking at is in the Ukraine setting, each patient would have to either go for their opioid agonist treatment, the HIV clinic, the TB clinic, primary care. They'd have to go to all these different settings, oftentimes kilometers from each other within the setting. Or they could go into what we hoped and planned was an integrated care clinic, which we have established. What we did was we are using a knowledge network model of interactive learning called Project ECHO. We're using distance-based teleeducation, where we use a group of specialists from the field of primary care, HIV, and TB, and in QI, and we're going to be training the clinicians and the nurses in all of these various different settings through weekly sessions that are typically started out with a didactic session and then followed with case-based learning so that they become sort of empowered, and it democratizes specialty care in these primary care settings. And they're connected through a telehealth video conferencing network. And then this information is then imparted to their patients on a regular basis. And you actually build up infrastructure through doctors and nurses and other people who transform the clinical practice. There have been a number of key issues that are important. One of them is really how do you measure the types of integrated care? We didn't want to measure just one outcome, so we have come up with using a Delphi method, the quality health indicators for each condition that we're trying to treat, and then come up with a comprehensive score. These are really quite important so that you have major factors at the individual level that comprehensively measure the health of an individual. We are also recognizing that with the financial changes in the healthcare system, that, like Shruti mentioned, that we're putting in a different, instead of incentivizing the patients, we're actually incentivizing the providers using a pay-for-performance method. And so we've been very specific about the structure and the amount, and we've done a lot of formative work to pre-specify these. And it will ultimately and hopefully build infrastructure and expertise in these diverse fields and then bring them together so that they can transform the healthcare within these regions. This is the structure of the randomized, cluster randomized controlled trial. Individuals will be people who inject drugs who are opioid dependent. They will be randomized within each of the geographic regions so that there is a matched specialty addiction treatment center and 2 primary care centers. And then the primary care centers will be randomized either to the pay-for-performance or the non-pay-for-performance. The implementation coaching strategy will be done through Project ECHO with additional QI. And we're going to have, because it's a type 2 hybrid study, we're going to have both patient-level outcomes and process outcomes that are going to be crucial. We're going to do this within 36 sites, within 12 regions, and the observation period will be over a 2-year period. What have we learned so far is that it's really important to have the Ministry of Health and the Ukrainian Center for Public Health really in right at the foundation of this. They supported this research right from the beginning, and they've been helping to implement it. We've really established national experts. We've developed the distance-based learning modules. We videotaped them. We've got them uploaded onto the ECHO site. We've done training. We've used the Delphi method to define the quality health indicators. We've already established the pay performance indicators and the payment structure. What we really recognize is there really is extra coaching that's needed to guide these primary care centers. There's a lot of anxiety and fear because of the regulations that methadone has to be housed behind a barred area, and we've been trying to think about how to move this into the general pharmacies at these sites. And then there have been some minor challenges with equipping the sites for distance-based learning, such as internet accessibility, which we've had to provide, inconsistent use of medical records and some referral systems so that we actually get data on a consistent basis. Thank you very much.
Okay, thank you very much. And I think that's a good segue into sort of understanding how we can facilitate these changes also at the healthcare setting. And we're now going to have Landon Meyer, a professor and director of the School of Public Health and Family Medicine at the University of Cape Town. He's also head of the Division of Epidemiology and Biostatistics. And Landon has done some very interesting work around integration, and particularly around HIV-infected women and ART during pregnancy and the postpartum period. So it'd be also interesting to see how we can take the lessons learned to the healthcare setting, too.
Yeah, thanks, Meg. I think I'm pleased to say we didn't plan it, but maybe there's some echoes with Frederick's work as well. Yeah. Hi, thanks for the invitation to be here and speak today on the interface of maternal and child health services and HIV care, focusing in on South Africa in particular. I have no conflicts of interest to declare. And I'll now spend about 10 minutes in total. First, running through very briefly the rationale for integrating MCH and HIV care services, really at a primary care level. I'll shift to speak about some successful examples, or what we think are successful from South Africa, and touch on a few other settings perhaps, and then wrap up with some editorial thoughts, I suppose, by way of challenges and questions that we grapple with in this area. So first, rationale for integration of MCH and HIV services. So I think everyone recognizes that the maternal and child health platform is a foundation of primary healthcare systems, particularly in low and middle income countries where HIV is most prevalent. And when I speak about MCH services, I'm focusing in on antenatal care, obviously providing care to pregnant women, postnatal care, which traditionally in MCH services focuses on the care for infants, and reproductive health services for women, particularly postpartum. And it's important to recognize that in a way that is different from our previous two speakers, there's a strong tradition of health seeking around MCH and for MCH services that's totally separate from HIV care and treatment services. And I think that makes the MCH HIV integration a little bit different, or the issues a little bit different from, for instance, injection drug use. But unfortunately, MCH services, certainly in South Africa and in many countries, and HIV services, certainly in South Africa and many other countries, have grown up and developed as highly verticalized programs. And what we see today on the ground is that a pregnant or postpartum woman and her child have to negotiate a highly fragmented series of services that seek to provide care to the mother-infant pair. So in our setting, certainly, and I think in many countries, it's not at all unusual for an HIV-infected woman to have to negotiate up to 5 different services between the start of her antenatal care and during the postpartum period, including antenatal care itself, potentially a separate obstetric or delivery service. General adult antiretroviral therapy services are often dislocated from the MCH platform, and postpartum, well baby or routine EPI services are also dislocated, and now there's of course an important shift to consider differentiated models of care, but one of the challenges that produces in this context is that it presents yet another service delivery platform that patients need to negotiate. With that said, there have been some really quite impressive examples over the last few years of the successes of integrating HIV services in different forms into the MCH platform during antenatal care. And it's really, if you think of the successes of prevention of mother-to-child transmission programs, these are really the successes of integration during the antenatal period, including HIV counseling and testing, short course antiretrovirals for PMTCT, and of course the shift to universal ART eligibility for all pregnant women. To give you one example of that from our programmatic work, this Kaplan-Meier plot sort of shows failures to ART initiation, so time to ART initiation in a group of women initiating antenatal care over a range of different service delivery models in the Western Cape province. And what I want to point out here is that when we, in our province, integrated ART services into antenatal care, the proportion of women initiating ART successfully before delivery increased dramatically. It increased further with the top curve with the introduction of option B+. But simply when we moved antiretroviral therapy services into the MCH platform for ART initiation, the uptake of effective ART increased dramatically. And I think lots of countries have witnessed similar changes. However, the postpartum period is a totally different scenario. And many writers beyond the context of HIV for decades have commented that the postpartum period in many ways represents a broken thread of the provision of care. In the context of HIV, I'm sure everyone here is familiar with the ongoing challenges in providing antiretroviral therapy during the postpartum period. We see all over the world, really, both in low-income and high-income settings, challenges with maternal adherence to therapy during the postpartum period, challenges in retaining HIV-infected mothers and their exposed infants in services, including challenges in the uptake of early infant diagnosis. But I want to point out that these challenges are not at all unique to HIV. And in fact, there's a long history of primary healthcare services struggling to engage women during the postpartum period. Postpartum care services, as I alluded to, tend to focus on infant care, and the intense focus, or the lack of a focus during the postpartum period on women is in contrast to the intense focus on women during antenatal care and obstetric care. So with that background, I want to shift to say a few words to provide examples of successful integration from the South African setting, and in particular to fly through the results very briefly of the MCH ART study, which was a randomized trial that we presented at CROI earlier this year that looked at the integration of MCH and HIV services during the postpartum period. And working in a district in Cape Town, we randomized 471 HIV-infected women on ART and their infants to an integrated model of postnatal care, which I'll say more about this, integrated maternal and child health services, and compared this to the local standard of care, which is that sort of fragmented, separated web of services with separate ART services for mothers and EPI and EID services for their children. We followed mother-infant pairs through 12 months postpartum and found that integrated postnatal care led to higher maternal viral suppression and better retention and care, which I'll show you on the following slide, as well as longer durations of breastfeeding. And so this slide shows the primary and constituent outcomes for the trial, and I don't think there's a pointer. The primary outcome was the combined endpoint of retention and care and maternal viral suppression at 12 months postpartum. And what we found was that under the integrated model of service delivery, maternal retention and care and viral suppression was significantly increased compared to the local standard of care, these fragmented services. So certainly we think that integrated services are good for HIV management during the postpartum period. The particular form that any integrated package of care takes really needs to depend on the local health system's context. In this case, our package of integrated care had integration at a couple of different levels of service delivery. We integrated antenatal and postnatal care, which in our setting is often fragmented. So the same providers would see pregnant and postpartum women continuously. We integrated mother and infant care by co-scheduling follow-up of mothers and infants together. And we, of course, integrated HIV with MCH care, so providing antiretroviral therapy during the postpartum period to mothers, along with trying to address other maternal primary care needs, such as family planning, infant feeding support, cervical cancer screening, and so forth. I just want to point out that these kinds of successes are not at all unique to South Africa or even to this study, and that there is a growing evidence base on the successes of integrated service delivery for maternal and child health in the context of HIV. This trial comes from Nigeria, a cluster randomized study published last year, which looked at 369 women across 12 facilities. And the intervention was a package of care that included integration in the form of co-location of maternal and child care and co-scheduling of maternal and child care, and demonstrated significant increases in maternal retention and EID uptake in that context. So I think we're starting to see more and more evidence of this kind emerge. So now, as I wrap up, a few words on challenges and questions that we're encountering, and I think it may echo some of the other things you've heard or will hear. So I have to share with you that integration, of course, is complicated. And luckily, this wasn't a provider who was involved in our study, but certainly it's not uncommon to hear people, service providers, who are asked to integrate services, that integration actually means more work. It's just multisyllabic. And indeed, the principal challenges that we encounter around integrated health services are around the burden on the provider and the system. I've alluded to the burden on providers, and I think we're all familiar with that, but I think there are also hidden costs that we don't necessarily recognize associated with integrating services and the complexity of changing services. And for me, and certainly in our discussions, this really points to issues of health system strengthening, and that an integrated health system is really one that's strong and robust to change. There are a few questions around integration that we grapple with, certainly. And the first of these comes back to this idea that both MCH services and HIV care and treatment services, at least in our setting, are strongly verticalized services in terms of their service delivery, but also their organization and their management. And we grapple with how we can retain in integrated services the efficiency, the focus, and the responsiveness that we see with vertical HIV programming, which has been a tremendous success, certainly in South Africa. We grapple with understanding the costs and the benefits of integration, and particularly the costs and benefits for non-HIV care. The data I've showed you here, and I think a lot of the data in this field, revolve around the benefits of integration for HIV care, but they're important questions to ask about the health of patients more broadly. And as I alluded to earlier, we're struggling with what to do with differentiated models of care and what to integrate into packages of differentiated models of care, particularly for women in the postpartum period. And this is my last slide, but I just want to remind the audience, because this might not be a very primary care-oriented audience, that we're not the first people to grapple with challenges of integrated primary care service delivery. This is something that's been going on, of course, for decades. And there is, in fact, lots of writing on optimal models for integrated service delivery. The Declaration of Alma-Ata is coming up to its 40th anniversary next year, I think. Yeah, next year. Yes, it's 40th. Okay, good. And I think it would behoove us just to keep in mind that this is an old problem that we're struggling with. So thanks very much to the organizers and to you.
Thank you. Thank you very much, Landon. And we're going to round out the session now because we've had multiple different types of services and locations. And our last speaker, Tom Ellman from MSF. He's the director of the Southern African Medical Unit of Médecins Sans Frontières, and he has more than 15 years of experience with Médecins Sans Frontières, working in HIV, TB, malaria, in Africa and Southeast Asia. And if anybody knows, he's also good at stimulating questions and helping us to come to answers. So over to you, Tom.
Thanks very much, Meg. Yeah, and I hope this is a primary care orientated audience, because I don't think any of this stuff's going to work if we're not thinking at that level. I'm going to be changing tack a little bit, because the previous speakers have, on the one hand, been talking about integration for services within a population, and to some extent I'm maybe talking about different populations here, but more similar models of delivery that these diseases require. And on the other hand, I'm really talking about something that for most people in low and middle income countries doesn't exist, namely access to non-communicable disease care. And I'll be presenting a little overview, then some of MSF's experiences, focusing on more recent experiences in Kenya, and then some reflections. No conflicts of interest. So what are we talking about? First of all, of course, non-communicable disease includes a huge variety of illnesses. It doesn't make that much sense to put them together, except that they're largely neglected in low and middle income countries. I'm going to be specifically focusing on the chronic non-communicable diseases, and particularly hypertension, cardiovascular disease, diabetes, but I always put fertility there just to provoke, because I think many of the issues around the models of delivery that we provide for HIV could be very valuably translated into better access to family planning and termination care. Then we talk about the comorbidities, and WHO have come out with guidelines recommending that we should screen for hypertension and diabetes at primary care level in HIV. And of course, for all of these things, it makes absolute sense, but the question is, screen in order to do what? And then that comes to the models. We don't have effective delivery models for non-communicable diseases for a variety of reasons that I will come to. And the real question for us is not about integration, but about introduction, about access to care for non-communicable diseases. And yesterday, I don't know how many of you were at the session talking about the leveraging of HIV exceptionalism towards global healthcare in general. I think this is one of those areas where there is a real onus on HIV experiences to be capitalized to deliver better approaches for non-communicable diseases. Remembering that while access is minimal, non-communicable diseases were around long before HIV was, and so was access to care and the questions around it. Our models of care, the differentiated models that people talk about, the community ART groups, the concepts of expert patients, the concepts of self-management, explicitly derived from European experiences primarily in non-communicable disease. And it's a bit of a paradox. If you look at this, this was experiences where we started integrating non-communicable diseases with HIV care in Cambodia back in 2002. And if you look at the curve, the graph on the right, you'll see we were using the fact that non-communicable diseases was a way to reduce the stigma of HIV, to lump everyone together in chronic disease clinics. But you'll see after 2003, the HIV care took off. We got many, many more people with HIV into these clinics than people with non-communicable diseases, and that's been reflected globally over the last 15 years as 3x5 translates eventually into test and treat all. So MSF's been working in non-communicable diseases in a variety of countries, but mostly thinking of non-communicable diseases essentially as an acute disease, either seeing people in hospitals or a slightly piecemeal approach to providing access over a limited time period without a cohort approach, a monitoring of the continuity of care for patients in conflict settings, those blue countries, migration and continuity of care from conflict in Syria, a variety of other areas. But it's the HIV programs, Swaziland, Kenya and Zimbabwe, where we are really explicitly trying to look at how do we develop a chronic model of care for non-communicable diseases. So, Kibera, it's a slum, one of the largest slums in Africa, in Nairobi, Kenya. We've been working there since around 2003, initially with an HIV cohort, and then since 2010, treating non-communicable diseases in an integrated way in the same clinics. I haven't, I'm afraid, had time to get the most updated data from the program, but we have over 5,000 patients by the time MSF handed over at the end of last year. And mostly these are people with hypertension, diabetes, or both, though we also have sickle cell patients, epilepsy, asthma, chronic kidney disease. But I wanted to focus, as I said, on hypertension and diabetes. So just a few findings from the program. As I said, large numbers of patients, and a fairly high loss to follow-up in the first 6 months. Remember, there's a quite high degree of migration within this program, but one of the striking things is the higher level of loss to follow-up amongst the non-HIV patients, which reflects many of the barriers and difficulties, including costs related to NCD care. In fact, in the Cambodia program, it was much greater. We had 30% loss to follow-up in the first year amongst the non-communicable patients, and only 3% amongst the HIV patients after removing mortality. Outcomes are fairly good, at least analogous to many Western programs, but because loss to follow-up is such a problem, we can't really say what this will do in the long-term impact on subsequent cardiovascular disease and complications. Because those numbers were so high, we implemented some of those issues and started to implement those basic components of differentiated care. Task shifting, and others have done this. The ComHIP program in Ghana, I think, has more experiences than we do, and a variety of programs, but task shifting coming into NCDs. Also to offload the clinics, as we did with stable HIV patients, starting to simplify care. First of all, with giving multi-month refills of up to 3 months of treatment, annual appointments for stable patients, and fast tracking for pharmacy pickup. All issues that are standard in Europe, but certainly not standard in many developing countries. And these medication adherence clubs, which are essentially the same as community ART groups, as the community clubs and facility-based clubs that we have in South Africa and in other programs, a number of other countries, where a lay worker provides a talk around the diseases that people, around HIV and NCDs, and people come together to get their drugs distributed there. And it works. We have a large number of people enrolling into the clubs. Generally, we did a qualitative study of this, and generally people were happy with it, although, interestingly, the non-communicable disease patients seem to get less out of it than the HIV patients, which isn't that surprising. And frankly, we're not clear that this is a useful idea, that they would be integrated, the non-HIV patients with the HIV patients, unless the opportunity costs made it much simpler to do that. But the really striking thing here is that we handed over last year, and of course, because there is no national assured free drug delivery and supply, we had to disband the NCD elements within these clubs. We did luckily manage to find partners who would continue some, but not all, of the non-communicable diseases. There's separate groups, often pharma-supported, providing either access to proprietary cardiovascular drugs or proprietary diabetic drugs. But there's a real problem in maintaining an integrated approach with that kind of background. So just to come to an end, just to remind us of some of these areas where we are failing and why we are failing to get non-communicable disease treatment, despite very, very clearly, in terms of burden of disease, it tops the list in most countries, over 40 million deaths a year, and diabetes rates, etc., rising greatly in almost all regions of the world. The similarities, these are lifelong diseases of mostly healthy people. In other words, mostly they have no reason to be within the health system other than because we tell them that's the only way they can get their drugs and their monitoring, and they require daily treatment for life. But HIV, much, much higher on the agenda. Why? Partly because we should acknowledge it's younger people, it's a deadlier disease. Without a year of treatment, you're at real risk of morbidity and death, whereas the numbers needed to treat, particularly in primary prevention, are much higher for NCDs. And there is a great deal of activism and advocacy that developed, partly for that reason, around it. And this led to a knock-on of investments that have had an amazing impact on access to care and on reducing mortality around the world. From simple treatments, fixed-dose combinations, heat-stable treatments, standardized guidelines, simple affordable tools and formulations, an assured quality drug supply. There's no pre-qualification system for most generic non-communicable disease drugs. The supply chains are a complete mess, and I will finish with a slide just to remind us of that. Decentralized care doesn't exist, whereas in Europe, much non-communicable disease management is largely demedicalized. In developing country settings, it's extremely professionalized and held within a small group of people in many countries. So task shifting is very difficult to achieve. And I'll jump through to the final point, that there is a global fund for HIV, TB, and malaria, and there is none for any of the non-communicable diseases, which means that free care doesn't exist, which means that leveraging price reductions in tools and pushing manufacturers to, for example, glucose sticks and the machines to read them are extremely expensive and very, very widely varying in price because there is no concerted push to reduce those prices. This is just a study from 40 countries, and I think it's been updated, but just to remind us that in most public sector of the 40 countries surveyed, the drugs were not available. Less than half of them had access to antidiabetics, hypertensives, asthmatics, epileptics, and in the private sector, not much better, but of course, much more expensive. So, where do we go next? We do need to develop more demedicalized patient-centered care and self-management. We could find ways to mitigate the lack of global fund for NCDs through leveraging price reductions. Things like buyers clubs have worked in the past. But we're not going to get anywhere ultimately in terms of the public health dimension without free, quality-assured drugs. And we need more pilots at scale, implementation research, rather than, I think, multiple incremental randomized controlled trials for every element to demonstrate how we can move forward. I'd just like to acknowledge the MSF field teams and MOH colleagues who've worked in many of these programs with us, and my colleagues in the team. Thanks very much.
Okay, thank you. I think we've had a diverse set of presentations, and we now have approximately 30 minutes or so to take questions and then to try to generate a bit of a dialogue around what's similar, what's different, what can one type of integration in a different setting learn from another, because there's so much diversity in some of this work and contextualization. So I guess we'll take a series of questions, maybe 3 or 4, and then open it up so that anybody on the panel could answer some of them if you want to jot them down. Okay.
Hello, I'm Flavia. I'm a gynecologist in Brazil, and I think my question is for Dr. Meyer. How about the integrate the male or the father into the mother-child? Because in Brazil we have a great problem, a huge problem, mostly in prevention of congenital syphilis because of this. Thank you.
Do you want responses one by one or a few questions?
Why don't we just go ahead and respond one by one so that in case our memories are failing us today. It is the last day of the meeting.
Thanks for a very nice question. Yes, I agree fully. I think the package that's integrated in the MCH setting will vary from context to context. In Brazil, and I think all over the world, men are critical. In South Africa, we've struggled very much around men, and I, for one, have given up on men. But in other settings, there may be hope. Yeah, absolutely.
Thank you. My name is Lydia Buzalira. I work with the AIDS Healthcare Foundation. I really do appreciate the need for integration, and this is very necessary in day-to-day service delivery. My question goes to Meg and to Lyndon in part. One, at health facility service delivery level, indeed, we do desire integration, and I think that we push the health workers, we really guide them, and sometimes I would say bribe them with our incentives to integrate care. The challenge I see on a day-to-day basis is from the national level and at guidelines level, and this is where I need help. You find that you are in a health facility and you have, let's say, 6 partners. All of them supporting you, and each coming with their own pot of money. So how do you expect this one health worker to do the integration, but at a higher level, we are not integrating? How do we then achieve what we desire? Meg, the question is, what path do we have in terms of guideline delivery at national level to ensure that even at that level we are integrating? My second question goes to the monitoring systems. Indeed, we do desire to have the data to support that integration works and that there is benefit for patients in terms of access and clinical outcomes. But if any of you have been to the health facilities where we are driving integration, you find a big pile of monitoring tools and a very large register if you indeed want, for example, the EMTCT register is this long, you know? So how do we create monitoring systems that enable us to get data that assures us of patient access, quality of care, but is simple and integrated? Thank you.
Okay. I thought I was just chairing. I didn't think I had to answer questions.
Sorry, no slack for you.
No, I understand. So because I represent WHO, it's fine that I take on this question. So I think you're right. You know, and when we looked at our 2016 ARV consolidated guidelines, we are consolidating across our department, and we did our best to bring in as many different other departments. But to be honest, when we looked at we do these scoping reviews to see what we could bring in around integration, around NCDs in particular. And what we saw is we don't want to duplicate what somebody else is doing. So we made those recommendations around bringing in mental health screening and management where appropriate, bringing in NCD screening or cardiovascular disease screening and management when appropriate. But the management piece was all left to look to your current guidelines so that we wouldn't duplicate. Now, if you're saying that that's causing more confusion, I could see that that could occur because I'm sure the NCD folks are putting out their guidelines in your country, and certainly at the global level, they put out some guidelines, but maybe not enough or not thinking about what this should be for the HIV patient. So I guess I take it as a request to go back and integrate now across all of the various departments and see what we can do a little bit better. And I should say that Tedros, who is the new DG of WHO, is very interested in helping us set up that universal health care platform, which really speaks to primary care and to make sure that we're working across departments. So I can't say I have the answer today, but we're going to take it back. But I'm going to let Landon take on the monitoring piece because I think that often comes out at the country level, how best to monitor some of this. Thank you.
Thank you, Meg. I think both parts of your question speak to each other. That is, the monitoring is one aspect of the system, yeah. And to ask a service provider to integrate services without a supportive system is a non-starter. It's crazy. And part of that system is policies and program design, and part of that system is the M&E tools that you're alluding to. And so
I think also in part the support, you know, we have health system strengthening projects and programs, and they're all still pretty much verticalized, but targeting one health worker. And we want them to deliver at the end of the day, but we are, in a way, not helping them. And I think eventually it impacts the data that we gather, but also the quality of care. To what extent do I trade off giving you the data vis-a-vis taking care of the patient, or taking care of the patient and you can't get data? And I think if any of you have been to a health facility to gather this data or to offer support, it's not unusual that you have a frustrated health worker or one that is not with you physically. Sometimes I go for mentorship visits to a facility and the guys say, oh, you're here, okay, this is your chair, this is your desk, take over from there. And you have nothing to do but to take care of patients vis-a-vis, do the actual work that you're there to do. So how do we now support governments and give them guidelines? Even for the old conditions like TB, even EMTCT, you find that they're still pretty much verticalized. How do we support at that level? With guidelines, with policy, to ensure that money is coming into
So Landon, maybe you
pot.
can give an example from how South Africa has really worked in the nursing setting.
I think it comes from, at least in South Africa, from a national and a provincial policy level, where the critical intervention, in a sense, may or may not be WHO policy. I think WHO policy sets the framework, but at a national level to ensure that there's an appropriate legislative environment, an appropriate service delivery environment, and the programs that are organized both nationally and provincially recognize the need of a service provider to integrate across a range of conditions. So the TB program has to recognize that a provider may be asked to provide hypertension care, for instance. And so I think maybe the level of the intervention is at the national or the provincial level, and in particular in a lot of these countries at the level of the PEPFAR partner, and encouraging the PEPFAR partner perhaps to think a little bit more broadly, which they encounter their own challenges. Yeah.
I think we have to move on to the next speaker and then in the middle. Yeah.
Hi, thank you for the wonderful presentations. My name is Marij van Skalkwijk. I work at Tiger Work in Cape Town. My question is for Landon. I just wanted to know how the integrated care services were actually organized. Was this nurse-driven? Was this midwives that were NIM-arted? And how many of the clients actually could stay in primary care? Because I can imagine if you need a doctor, you're referred out to hospital level, and it could be either ANC or EMI or whatever. So I would like to know how many actually could be kept at primary level. Thanks.
Thank you. This was all nurse-driven, sort of PHC-trained nurse-driven. In South Africa, it's called NIMART. And to get back to one of the issues that the previous question raised, was part of the enabling factor is legislation that allows, in South Africa, that allows nurses to dispense antiretrovirals, which wasn't routine and was a legislative move that had to be made to enable this. Regarding the question about how many women could be managed in primary care, what we found is that a substantial fraction of women, as you're suggesting, were referred out of primary care for obstetric care around labor and delivery, but the vast majority were referred back into primary care postpartum. And so we had women who were referred out for labor and delivery and referred back into the same service during the postpartum period. And that continuity worked quite well.
Yes.
Yeah, hi. Alistair Reid. I'm the Tuberculosis and HIV Advisor at UNAIDS headquarters in Geneva. But up until 2015, end of 2015, I had the privilege of working in South Africa and worked under Jürgen Pillay, who had the vision to develop, before the term differentiated care model was trendy, an integrated guideline for retention in care, linkage to care, retention in care, and adherence to treatment for HIV, TB, MNCH, and NCDs, drawing on the MSF Khayelitsha Chronic Club model. And I think in South Africa, as we've heard, there is a much more a move towards a client-centered approach. Rather than seeing a disease walk through your clinic door, you see a person. And I was quite amazed that you actually managed to talk about integrating MNCH and HIV services without mentioning tuberculosis. Neil Martinson presented some data that 4% of HIV-positive pregnant women have undiagnosed, asymptomatic undiagnosed tuberculosis. So I just make a plea to not forget tuberculosis amongst the integration. Thanks.
We would never forget tuberculosis. Sorry, for a time I didn't include the TB screening.
I think we're just trying to circle the questions. It's great.
Yeah. No, sure. So I just would like to share a bit my worries working in Mozambique. Sorry, I'm Gaël Caquin, working currently on HIV. About that elephant in the room that you pointed at, London, regarding whether we should not envision and support a shift in the approach that healthcare are provided, in fact, in most countries. Meaning, okay, primary healthcare is going to subsist, but we want now individualized care, we want integrated care, and we ask this to staff, which is already task shifted, overburdened, and sometimes underpaid and working in very poor conditions. So how far can we go like that without a meaningful approach to really train from the beginning people for higher quality? Even recording information is something that is not in the culture of most of the systems. And so for chronic disease, it's very important. And so I think it's becoming a bit schizophrenic to massify, task shift, while we are not providing the means to really enhance the level of caregivers in general at a massive scale. So maybe on WHO side or the Global Fund, which has a SSS component that it really strives and fights sometimes to try to materialize for good at scale, or on the other side from MSF, who are centers of excellence who could be hub, to have training going to high level, and we have one for HIV, which is working pretty well in Maputo in Mozambique. So what is being prepared or envisioned, at least, if we want this to happen? Because without strong support for HSS, it's going to be catastrophic.
No. I mean, I think it's a critical point, and when we talk about the enablers of access to care, talking about task shifting without taking into account that even without added tasks, there are huge gaps in the health worker resources at primary care level is avoiding the big problem. So definitely we need to ensure that there is a push for more human resources for health in these centers. But mitigating whatever lack of human resources for health, while bearing in mind that if patients cannot get care at one point, we're going to lose them to care, or they will present very late, means we have to find a way. And for me, the fundamental issue is simplifying as far as possible. That certainly includes the issue of monitoring and evaluation, and I think we're far in HIV from being as simple as we could be, often because of donor demands rather than because of health system demands. But I think that whether it's HIV, whether it's diabetes, whether it's non-communicable diseases, in all cases there is much more we could do in simplifying and ultimately transferring more and more responsibility, or at least ability and empowerment for patients to manage their own care and with peer support, such that we wouldn't need to overburden. So just as a very facile example, if somebody has to come every month to the clinic to pick up their drugs and to be seen, that's going to take 12 times more time for a health worker than if they come once a year. And we already know that once a year for a clinical appointment is safe for stable HIV patients. We can take that analogy to many, many other diseases, and certainly to non-communicable diseases. So let's not take the foot off the pedal in trying to get more human resources for health, but there is a hell of a lot we could do by simplifying care.
I wonder if Rick could talk about how your program in a different setting, though, is really working on the healthcare worker motivation and facilitation. Yeah.
So I think one of the threads that I heard across a number of the questions and comments really has to do when you've got a set of guidelines to do X, Y, or Z. So how do you do that? And those guidelines typically will happen at the policy level at a higher level. And just to remember that your guidelines are going to give you a system that will do exactly what you design it to do and nothing more. And it will not do anything more unless you have an active facilitation project. So you can set up guidelines all day long, mother-to-child transmission reduction strategies, and you can see uptake and adoption that varies from place to place unless there's an active facilitation. So anytime these things happen, there really needs to be sort of an active coaching and facilitation, and you sort of have to know the context. Can you do it with sort of mobile media, or do you have to have trainings? A one-time training is seldom insufficient, or is often insufficient to do that. So part of what we've done, and we're working in a middle income as opposed to a lower income setting, is using the technology of your smartphone, of your computer, et cetera, like that, in order to sort of have ongoing coaching. And that coaching often needs to include some sort of quality improvement. People need to be able to look at what you're doing. And so if you're setting even more minimal standards of monitoring and stuff like that, are you meeting those thresholds? And so I think that those are the key things. So I think that there is part of it, make it simple, but also just make sure that there's a QI. Are you doing what you intend to do? And that's always part of this implementation process. And I think people forget that key element, which is facilitation, because without it, your intervention, you get much less impact out of it.
Thank you very much. Good afternoon. My name is Mutinta Nalubamba from Society for Family Health in Zambia. My question is for Tom. I may have missed it in your presentation, but I just wanted to find out the proportion of, in the integrated NCD HIV clubs, how many of those clients had NCDs without HIV, and how many actually had a combination of NCDs and HIV. And then also for the facilitators of those clubs, were they, was it one facilitator for all the conditions, or you actually had separate facilitators, and how the club actually was conducted? Thank you.
Okay, thanks for the question. With regard to the detail on the numbers, as I mentioned at the beginning, this was a bit of a last-minute invite, and we haven't finalized our analyses, which we're doing since the handover of the program. We're now doing a full analysis of all of the data. What I can tell you is that at the time that we did the previous analysis, there were relatively few NCD only. So the majority of the people within the clubs were HIV without NCDs, which was about 70%. The proportion who had NCDs alone was about 10%. But that was at a time when they were still trying to scale up the access. But certainly it was true that there is less interest amongst the NCD clients, particularly when we managed to guarantee a fast-track service for drug pickup than for the HIV, and that the majority of the discussions held were relating to HIV. There was a club facilitator for each of the clubs. There were, I think, about 4 or 5 different facilitators, and they were all HIV positive. But there were external and facility-based NCD expert patients who would come in to facilitate specific discussions around diabetes, hypertension, or epilepsy, where they also tried to group a group of patients. But certainly this issue was clear within the clubs, that not everyone was interested in the content of the talks, and particularly a stable NCD patient doesn't really want to spend an hour sitting, listening to a talk about something that they're not suffering from. I think I got the answer there.
Hi, this is Katrina Haug from Imperial College. Well, first, thanks for putting a session together on this important topic and for the great presentation. I really have a question for all speakers. You talked about the benefits to patients on the outcome side of integrating care in terms of improving quality of care and continuity of care, which is great. But I wonder whether you looked also on the cost side, because the joint delivery of intervention and the integration of care could mean that the total costs are actually lower than providing these services separately. And I just realized that there's very little evidence on this question. Thank you.
So I'm happy to start. So that's a great point. In the first phase of our study, we didn't incorporate a formal cost effectiveness analysis, but we have collected detailed cost data. And in the second phase, we actually have a formal plan. And so we recognize in particular if the country is going to adopt the model, even if we demonstrate that it improves outcomes without that cost data, they're not likely to implement it. So we have planned it, we just haven't done it yet.
And in Ukraine, in the cluster randomized trial, a pre-planned analysis is the cost effectiveness, really looking also at the question of integrated care versus non-integrated care, but what is the incremental cost and perhaps cost benefits for the pay-per-performance incentive. So that's a really important point, and none of this will be adopted unless there is a cost effectiveness component, I don't think.
I agree. A critical question. In one of the foibles of conference scheduling, the cost effectiveness data on the intervention I described to you was being presented at the same time as this session in another room in this building. I'm sure it's available online. The one thing I would say is that a lot of people presume or assume that integrated services are more cost effective, and I think it's an assumption that needs critical unpacking, because there are tremendous efficiencies associated with verticalized care. And so I do think it's not a simple answer.
I won't add much. I think in response to that, I think there's also a need to recognize that from a patient-centered perspective, regardless of the health system costs, integration makes your life easier. So we do need to be very careful about how we go about those analyses, but absolutely cost effectiveness is critical in this. For NCDs, as I said, the costs are not yet being met because people are not yet getting NCD treatment, but it is something that we're looking at the moment. We're doing costing analyses around this in Kenya. Thanks.
Sorry, me again. Just quickly, I would like to stress caution on this idea that integration increases workload on a healthcare worker. If you have an HIV-positive pregnant woman who has 2 children and has tuberculosis, she may have to come to the HIV clinic on Monday, the antenatal clinic on Tuesday, the early infant diagnosis or vaccination clinic on Wednesday, and the TB clinic on Thursday. Similarly, an HIV-positive drug user with tuberculosis may have to come, for harm reduction services one day, TB services the next day, HIV services the next day, often provided by the same healthcare worker. So I find it very difficult to see how that could be more cost-effective than for both for the health services and for the person than providing client-centered care.
Okay, I think that was a comment and an advocation for moving forward with integrated services. I have a question for probably the first 2 speakers, because we didn't speak too much about how we're handling people who inject drugs, and the situation in many of our countries that are actually seeing the highest rate of new infections around the world in Eastern Europe and Central Asia. And I think sometimes we're actually, we don't talk about some of the real challenges of getting treatment to populations. And I wonder if in any of your studies you're looking at, in particular, Shruti, your study of getting people onto therapy within the 7-day period that we'd like to get them on by either having ART at your OST site or at these integrated centers, and then also working with the perceptions that people who are actively using, that they can start ART even if they're not actively sticking to their opiate substitution therapy. And how are you handling that? Because there was some very dramatic data I saw yesterday from Southeast Asia where the perception of would a clinician put somebody on antiretroviral therapy if their CD4 was less than 17 and actively using. Is that your presentation? And so speak to that, because it was astounding to me that even at the lowest CD4, there would not be ART given to people who are actively using. So if you could speak to this.
I can speak a little bit to that study and talk about what the implications may be. This was a survey of HIV providers, several hundred, and it was an experimental design where they were presented clinical case scenarios, and there were certain key populations that they would not initiate antiretroviral therapy immediately, even with very advanced disease. And if you were an active drug user, if you were recently released from a prisoner, what was interesting is that so about 55% of providers would not prescribe for that particular patient. If you introduce them to methadone, it went down to about 10%. So there was about a five-fold reduction in that just by sort of providing treatment. But there's still going to be a number of people out there who are, let's say, amphetamine users who won't get on that sort of treatment. I think we really need to think about, especially in these middle-income settings, about moving treatment with some task shifting that's just based on the guidelines, test and treat. And many places are incredibly resistant to doing that. I think that they've done a much, much better job in sub-Saharan Africa in doing some of this, but it's still remaining in these very specialized settings. And so I think the next generation of questions in these settings is to really move it out to more community-based treatment with sort of monitoring systems. Like I said, once again, you're doing it on your phone with some kind of apps or something like that. We've really got to democratize treatment.
Yeah, I would agree. And I think a challenge for us, when we started our model, we anticipated that we would be delivering ART within all of our ICCs, and it just became logistically impossible. The government wouldn't, just a lot of barriers with that. I think that is the way, because the site that you saw that did the best, Imphal, that was the place where we were delivering on-site ART, right? So it obviously made a difference. In our next phase, we're hoping to move more towards that model as much as we can, because even that idea that, for the other sites that a peer health worker could take someone, it's still an extra step, right? You have someone helping you through the line, and also it was to combat some of those stigma issues, right? Because that's a key reason why drug users don't even want to go to the government center, because they feel like they're going to wait in that long line, still be treated poorly, and then denied treatment. So I agree with Rick completely. It has to be a different model, and so we're pushing for that within our sites as well.
Okay, I think we've reached the end of our session. I think it's been very good. Maybe the next time we come back a year from now, we'll see more government integrated programs that are seeing this more at either a sub-regional, regional level, where we're actually going to be able to see some outcome data. But thank you for taking your time and some of the excellent, excellent questions. I pass over to my co-chair for any closing remarks.
Yes. Well, it was a very nice session and very interesting. And for my own, I believe how important is the integration of care. But in some experience, we could show how important to improve this integration is the role of counselors. And maybe it's a way to follow, to reach better results in improving the results, both in treating addiction and drug use, and the results of ARV therapy. Okay.
So thank you. Enjoy your lunch and the rest of the conference.